Okay.
Good morning, everyone. Let's have a seat, please. So we can start with the second day of this very nice meeting, seeing everybody from around Lebanon and all the areas abroad. Today's session is facial aesthetic surgery. I'm Firas Hamdan, and my co-chair is Dr. Romeo Faddoul, and he's also the first speaker for today, talking about costal cartilage graft for rhinoplasties warping study. Dr. Romeo, please.
Thank you. Good morning, everybody. I would like to thank you very much, the scientific committee, for this kind invitation. So we talk about something that is very rare, but it happened. And this study is about the costal cartilage graft warping study. Not happened. So costal cartilage graft is one of the most useful materials in reconstructive plastic surgery. So only a few articles in our review were presented about the technique or how to split the costal cartilage grafts and if it's warping or not. So I went to the cadaver lab and tried to show you all the details about how to do it and what kind of, which cartilage graft is the best for rhinoplasty. I have no disclosure for this study. So we have this kinds of rhinoplasties. The past was, it was Joseph, that is a reductional area, then the present conservative, and then recently we have the structural and functional area. So we have some kinds of grafts. We have the visible grafts and we have the hidden grafts, it's no visible grafts. Usually the costal cartilage grafts are no visible grafts. And we have some problems with no visible grafts because we have some problems with them because they are not visible, but we have variables. We have the warping, we have the resorption, we have malposition if you are not correctly fixed your grafts. So in secondary deformities, costal cartilage grafts are very good options for secondary or tertiary rhinoplasties. And because of we have many different kind of physicians doing primary rhinoplasties, we have many complications, and we have for us or for specialties, plastic surgeons that are specialty in rhinoplasty, we have many revision rates in secondary or tertiary rhinoplasties. So we have many, only some of articles in the literature that talk about complications in using costal cartilage grafts. These are some of them. So this is a patient of mine that I did a costal cartilage graft, like a secondary rhinoplasty, and after 3 months, she came like this, with some deformities. And I asked her, you need to do this to put your graft back to the original position. There's another patient of mine, you see, third revision rhinoplasty, 2 costal cartilage graft. This is the pre and post. Like you see, the warping 3 months after. Another patient, 39 years old, secondary revision rhinoplasty, also the deformity. You can see here the warping and 4 months after. And this is in the literature. I found only graft that have this kind of warping. So my study is an experimental study that I did in cadaver lab. So our goal is to show the deformity we have and how to manage these deformities. And this is what I did. So I went to the cadaver lab. In Brazil, we have many cadavers every single day. So I did 54 cadaver labs. The method was thoracotomy. I removed costal cartilage graft from the 2nd to the 6th at the osteocartilaginous junction. At the right side, without perichondrium. At the left side, with perichondrium. And then I split in the middle, craniocaudal, and then I did 2 or 3 grafts, about 2 millimeters each. So these are the sequence of the study, the thoracotomy, and then removal all the cartilage from the 2nd to the 6th, and then split in the middle, and then from craniocaudal, and then I split in 2 or 3 grafts. And then I measure every one of these grafts, and after this, remember, right side without perichondrium, left side with perichondrium. And then all these grafts I put in the saline solution, 0.9%, 24 degrees, and I took pictures every 5 minutes. And then we can see the warping of each of these grafts. So this is before and after 35 minutes. And you can see the second right. D is from direita in Portuguese, so D is right and E is left. So second right, third right, and this is before, and this is after 35 minutes in the saline solution. 4th, 5th, and then 6th, and then the left side. Remember, left side is with perichondrium. So we have this this deformity, and here you can see the exact craniocaudal, split in the middle, and then split in 3 different grafts. Go to the rest in the saline solution, 5 minutes, 15 minutes, 30 minutes. Then you can check. So after this, we measure, like I told you, we measure all the length of all grafts, and then I measure the angle of warping. Negative degree is this deviation for the natural side, the side of perichondrium, and positive degrees is this deviation for the cutting side, the cutting face. So these are some of the results I have. I'll put all them in a graphic like this. So this is the second right cartilage graft without perichondrium. The third, like you see, we have the 4th, 5th, 6th, and also we have the left side with perichondrium. So 4th, 5th, and 6th, we have the biggest deviation. So like conclusion, we have the costal cartilage graft are smaller in dominant side, usually the right side. Younger cartilage warp more than older, because older patient has more deposit of calcium and more calcified. So there's, as younger is your patient, the warping is higher, the rate. Grafts from second costal cartilage has less deformity after hydration. And central grafts, both scalping cutting sides, warp less. So when you got your graft, try to take it from the central side of your costal cartilage. And grafts from the 4th costal cartilage have biggest warping deviation. Grafts with perichondrium has more warping than without perichondrium. And there was no significant difference between warping deformities of symmetrical grafts from anterior or posterior half. Then I paused the study and tried to do something that I will do another study making a suture of these grafts in steel form plate, simulating the septum. So all the time we try to fix the patient's grafts in the septum. So I did the suture of all these grafts again, but I suture in the steel form plate, simulating the septum, and then again I put all of these grafts in the saline solution and rest for 30 minutes. And I will see if the warping is still maintained higher or not. So this is with the suture in the plate, this is without. So when you fix your costal cartilage graft in a steam foam plate simulating the septum, the warping deformities is less. So the pre-results of the new study, grafts from the 4th, 5th, and 6th cartilage sutures in the styrofoam plate had less than 2 degrees warping deformities after 40 minutes in saline solution. And remember, without this suture, the deformity is up than 30 degrees. Straight rigid plates with the same measure of the grafts are resistant to the force of spring of costal cartilage grafts. There is no significant difference in shape change of the central grafts with or without rigid plates. So for future studies, we should warm the saline solutions to 36.5 degrees because it's our temperature is the temperature of the blood. Histologic of the cartilage at different ages to show that calcification, there's some influences of the calcification. Thick and long graft with steel wire inside is something that in Dallas they are doing, Southwestern University, they are doing some wire inside the costal cartilage graft to avoid the warping deformities. Thin and thick graft fixed in sheet of steel form. This is in progress. We're still studying this analysis. And thin but then thick grafts, which is the biggest deviation also in study is, and also long-term evaluation that we are studying. Thank you very much for your attention.
Thank you, Dr. Romeo. Our next speaker will be Dr. Fabio Fantozzi from Italy, speaking and shifting now gears from the nose to the neck about cervical lifting.
While we do the change, I'm sorry, I have to make a small announcement. We have a 1-hour session by Dr. Sterodimas, who unfortunately could not make it, and he wanted to do a Zoom. Unfortunately, again, the setup is not available. So we have a whole session which is gone. So now you have free time for all the speakers to talk as long as you want, and then we can have a very long coffee break. Unfortunately, I don't have a cigar, so it's okay.
Okay, Doctor.
Okay. Good morning. I would like to thank all the organizers of the conference for the pleasure to stay in so beautiful country like Lebanon. And my name is Dr. Fabio Fantozzi, and I took my residency in plastic surgery with Professor Ivo Pitanghi, and now I work in Rome, Italy. This painting is laid in Krakow, is Leonardo da Vinci, 1484, 1485. And so we can see like Leonardo da Vinci show the beauty of the face in that time. If we compare with this model, we see that after the time something is changing. And is changing the beauty during our life. We see how is the beauty in 50 years can change. It changes the beauty in different races. And plastic surgery And in the plastic surgery, we have very difficult job that to treat the face. And the face, the beautiful face, is the result of the perfect proportions, combination of the proportion. And so it's necessary to study this proportion to achieve the best result. And when we see this painting, this is Il Ghirlandaio, Giovanna degli Albizzi, is 500 years ago, we see that the artist knows, the classic artist knows very well the proportions. And this face is beautiful because exactly is geometric. We have all the proportions are in harmony. And but anthropometry is not only lines, but angles. We have angles between the front and the nose, between the nose and the mouth, and many other information that we can have, from the beauty. We can study, we can have the best result in the hand. And we have different approach to study a face, different scale of anthropometry, and but in the hand it is important that you look before the face, before to do your surgery. Today I talk something very easy, is the lifting of the neck in this form. Normally we can arrive in your office, some patient that doesn't want to go in the operating room, doesn't want to do something in the face, no filler, something different. And so that is my approach, very easy to treat the neck, only local anesthesia. We can see I only mark the line under the hair, and this is the incision, as in the line of the hair. All the incision is behind the hair, and so after the surgery, practically is invisible the scar. And this is the area of detachment, and so it's very small area, and that's the point that you can make the traction of the muscle. And we start very, I suggest always very high concentration of adrenaline to 1,000 of adrenaline. That is good percentage that you practically you don't use the electric bisturi. And you start, to, I use a lot of bisturi in the beginning to prepare this detachment. And this is the incision. It's very little bit, and you go very fast. In 15 minutes, you prepare this after the incision, the detachment. Always this area is important to be not too much deeper, because we have some vessels, some nerve that is important to maintain. And you prepare, you go. It's very simple, nothing of difficult, and I do very easy. And after this detachment that arrive under the hair, we arrive in this situation. And so you open this window, very easy. It's not complicated. And so you open this window, and after that you start only to make some stitch. You can use in the main 3 or 2 nylon, I prefer, and after you make this plication of the muscles. You see after this point how is strong the plication. Imagining this in some women, very thin skin, you have very strong traction, and practically the surgery is the only point important. The traction of the muscles is a little bit, you can do in 2-3 points, but it's important with very strong suture, with nylon, I suggest. And after that, you remove the skin in excess. The only point that you have a little difficulty here, only to combine after the traction, the here, but with a little bit experience you can do it. After 2-3 times you arrive very easy to do that. And practically After that, the surgery is practically finished. You remove only a little bit of the skin in excess behind, and it's finished the surgery. And we can see the result after 24 hours. And so you have no bleeding, no seroma, no injury of nerve or something. And so it's very easy. The patient is extremely satisfied because immediately you see. And all the patient that doesn't want to go into the operating room, and so only local anesthesia. You say operating room, only local anesthesia. And you can treat the patient that nobody will arrive in the operating room. But you can very easy surgery. You can have a very good result. And I try to, something a little bit complicated. And so male, like that, very fatty, it's not easy. But I tried with liposuction and this technique. And you have very good result. And this is a photo after 2 weeks. You can see the result, very, very easy. And that is very big neck, that is not easy. But in the hand is working too in very difficult neck. And so that is the same with very big amount of fat grafting in the face, very big amount. And my conclusion is, I know that facelifting is very complicated surgery. You have some patient that doesn't want something very simple. That could be possible an option. I remember the words of Ramil Sinder, that was a professor of plastic surgery from Brazil, that said always, incredible result, incredible risk. And so sometimes something very easy can resolve your problem, and you can have a very good result, a very safe post-op. And thank you for your attention. I want to invite everybody for our Congress that we organize in Capri. That will be a video conference, and it will be a pleasure to stay all together. Okay, thank you very much for your attention.
Thank you, Fabio. The next speaker is Dr. Firas Handan. Talk about the endoscopic forehead lift for male patients.
Yes. Okay. So good morning again, everyone. Lecture will be today about targeting the male patients who's, as Dr. Fabio just mentioned, they are a little bit tougher to deal with, especially when we're dealing with their face. How to hide the scar, where to put it, the heavier tissues overall. So this is always a concern. So I launched something called the 3Q lift. We'll talk a little bit about the technique and the indication, but where did the name come from? It's about the three things always the patient come in, especially the female. The question is, doctor, can you do this for me, lifting my forehead a little bit? Can you do this for me? And this one with one stitch, So this is the hiding the scar and doing the impossible, with no scarring and no evidence of anything that's being done there. So this is where that 3Q came from. And basically, it is a combination of an endoscopic forehead lift with more of a mid-face dissection. But, there's a lot of words outside. Is it endoscopic facelift? Is it an endoscopic deep plane facelift? Is it an endoscopic neck lift? Is it an canthoplasty? Is it a blepharoplasty? Will it, hide my nasolabial fold completely and make my marionette line disappear? How about my jowling? How about the need for Botox for the future? Will I ever need Botox? These are the questions that come to me every time we sit down with a patient. You know, we are all plastic surgeons here, and we know there's no magic. So we have to be very realistic with what we are promising our patients and what we are, gonna deliver to them. So the aesthetic concerns are addressed, especially for the male, the brow heaviness, the deep forehead wrinkles, as well as the functional concern, if they're coming in with hooding of the lateral eyes, and sometimes blepharoplasty is not helping them. So a usual patient profile for 3Q in general, and then we will target the men part of it, is young patient can be done because something is hereditary where they have a heavy set brows, and in Arabic we call Doctor عندي بطانة هون ما تبطينة الحاجب, and it's not an eyelid problem, it's more of a heavy brow problem. And they have done an upper blepharoplasty 1 time, 2 times, and sometimes 3 times, but this little part of the skin on their lateral brow is not helping, and the ladies are pulling their hair in a ponytail. And the youngest patient I've done is a 16-year-old lady brought to me by her parents with 2 big bald spots from here. Since she's age 12, she's pulling her hair so tight, she ended up with 2 big bald spots, and now she's going into depression and having psychological issues. So we got the permission of the parents to undergo this procedure, even on that young. And sometimes, when patients are coming in, doctor, I want to do toxin to lift my brow this much. When we tell them, look, the toxin will work on where the muscle will take your brow, will not pull you higher. And in my experience, threads in that area doesn't work, and we have limited amount of filler that we can do for this. So the more important is the preoperative assessment, detailed patient history, physical examination. We talk about the contraindication if there's any, and then the expectations of the patient is the most important, because they're thinking, I'm coming to Dr. X, he's the master in this, and with 1 operation of 1 hour, I'm gonna be not needing anything for the next 50 years, which is not correct. All right? So I demonstrate to them when we're doing anything endoscopically, we're not removing excess tissue. So anything that's excessive is being repositioned, but it's not being cut. There's no cutting there. There's no removing of any tissue. It's just repositioning of the tissue in a more vertical, oblique, or upper way. So the anatomy is here we need to worry about, the muscles, the nerves, blood vessels, of course, the landmarks of endoscopic approach, we'll talk about it, and the complication. The most common complication, and most of them are transient, would be the frontal branch of the facial nerve, frontotemporal branch, could have some paresis, so we might have some irregular motion of the brows, one side moving much more than the other, or normally, and the other one weaker. And this should be resolved within 3 to 4 weeks. The longest I've had is up to 6 months, but most of them are resolved within the first month. And if it's really bothering the patient, you can do toxin to the good functioning area, just a little bit to calm it down, and by the time with the 3 months the toxin wears off, they're back to normal. Bleeding, we haven't seen any much bleeding. The 2 times we had bleeding was from the skin. It was just add 1 more stitch and that's it. Some people do use the drain, and I don't use any. Alopecia at the site of incision now is very rare because we're not targeting the skin, we're not pulling the skin, we're repositioning the muscle, releasing it from the periosteum. So now it's very rare. Before, when we used to do the temporal lift, only skin only, that was a problem with putting too much on the skin and putting stitches there to hold it. So alopecia has become very, very, very minimal now. So as we said, asymmetric brow movement and insufficient elevation. So hematoma we talked about, numbness and itching. We have complained that 3 months, 4 months later, say, doctor, I'm itching too much in the back of my scalp. It's sometimes very, very, very aggressive, and I wake up at night, itching. This is like 1 for every 100 patients. Zyrtec or antihistamines does work. I don't know the mechanism of action, but this has been reported, and it's just to get used to it with time, and that's related to the periosteal elevation all the way to the mid-scalp area back there. We are seeing more and more prolonged periorbital bruising and ecchymosis, and the more we talk about it in the meetings, the more we realize that it is the residual hyaluronic acid filler while we are repositioning the tissue up, is holding, you know, the edema, especially when we have the ligaments that are there, and it becomes like a new festoon that was not present before. Treatment for that, if it gets prolonged more than 1 month, hyaluronidase, you know, in a cannula to spread it all the way around, and sometimes we see filler coming out from the entry point, and sometimes adding a bipolar radiofrequency needling like Morpheus or other machines that will shrink that area there and will help us with that. So the tools, endoscopic camera and monitor, are now only for backup for me, since we've been doing it for such a long time. You can do it not blindly, I mean, you can looking through there, and if there's anything that, you know, oozer or something that's oozing around the bundles where we need to have more control, we put the scope and we do use bipolar there. Serdev needle, I'll show you what that is. It's a long needle that will pass the cables posteriorly to support the forehead. And then, of course, the fixation devices, you know, sutures, you can use Prolene, PDS, and for the mid-face, for some patients, we use the endotyne ribbon. This is the Serdev needle. There's different kinds, and I use the longest one. Serdev devised it for the butt, but we're using it into the forehead from posteriorly, anterior, and backwards. And these are the surgical steps. Incision placement, dissection, periosteal release is the most important thing, I believe, in this technique. And then, you know, you fixate it with, as we mentioned, the help of a Serdev, 21 centimeter long, and then suturing. So the backup use is for the camera, as we mentioned. Telling the patient that they're going to look like an avatar, that's what I've been using mostly. They're going to be so swollen, you know, swelling in their face, because we release periosteum all the way to the supraorbital rim, laterally down to the lateral canthus, and then also we go in here and we go posteriorly. So all that swelling will set into their face, and I'll tell them, you know, you might, you know, you will hate me the first 10 days, but you have to go through this. So if you have any social events, your husband, whatever you want, you know, you're going to be looking like an avatar for 10 days, and now they're accepting it. Back to normal within 1 month, but usually they can go back to normal within the first 10 days. We address any asymmetry at 3 months. Nerve function is back to normal. Less than 5%, you know, we show them where they were, where they become. 100% or, you know, almost 100%, there's improvement. You know, 5%, they come to me and say, doctor, could you pull more? And I tell them the pull is from here. And if I can pull you more from here at 3 months, there is room for a modification or a revision, and that rate is about 5%. It can be done under local then. Usually we do it with IV sedation. It can be done under local. We release the 2 stitches that are still there, you know, whether Prolene or PDS, and then we can release a little bit more and pull it more, and there'll be also no risk of alopecia then, because we're releasing the same level. All right, so the success rate we talked about, and then let's talk now about the males. So you're doing it since 2019, mostly for the women, and then when we go to the male, it comes in as, you know, the brow elevation. You know, we don't want to tell them you're getting a forehead lift. We're resetting their brow at a higher level, and these are the levels where we are in. We're coming underneath, okay, the superficial temporal fascia, between the superficial and deep temporal fascia. We're coming down to the temporal crest, releasing it, and coming from the forehead, and I'll show you on the other one, releasing that temporal crest. So periosteum in the forehead, going into the deep temporal fascia here, releasing the periosteum all the way along the orbicularis, and then going into underneath the SMAS, both down over the masseter and also over the zygomaticus major. So this is the plane that we are using, and these are some dissection. Dr. Romeo, of course, has done tons and tons of those. I was just talking to him about that, and it would be nice to demonstrate it in his lab one time and do a study of about 50 cadavers in 1 weekend, like he promised me. All right, so in the front, we come down, and we are all the way down, you know, as the neuromuscular bundles, but even we can release the procerus and the corrugator muscle attachment where they need to be able to lift the whole thing out. So if we can see, this is the frontalis with the procerus and the corrugator and the orbicularis. So we're coming in from here, and the access point is from here. So we come in here over deep temporal fascia, and we get all the way down to the temporal crest, and I stop here. And then I come down from here, underneath, straight on periosteum here. and we will join that ligament there, and we will have subperiosteum, supraperiosteum all the way to the temporalis fascia, and then we come down and we release this way here, and come down over the zygomaticus major on this side and on this side, and there will be the whole flap will be able to be moved in one direction upwards. All right, why in the male is this challenge? Because these were the previous incision techniques for where you can place a forehead lifting, and for males, coronal, trichophytic brow lift, mid-forehead. I've used it once, direct brow lift. The last three were unsatisfactory to me, and that's why I shifted. And then we moved to this. This is with the direct brow lift. He has prosthesis in the left eye. It's a prosthetic here, so you can see the difference. And he had the hooding. So we told him we will do a blepharoplasty and a forehead lift, direct brow lift, sorry. He's happy, but I'm not very happy with the position of the incision and the way it looks. And he never complained, but I was not happy. And this is another one who came to me from Australia. Both of them were done in Dubai. He has hooding, vision restriction, and the angry look. And blepharoplasty will not target this, and will not target this. So what we did on him, we used his same crease to place, instead of going to mid-forehead, so I said we'll use the same crease to place the incision, and we do the direct brow lift on him. And this is him, and he's very happy. But still for me, I'm not happy with the results, and he's very fair, so you cannot hide it. And he's not a female, you can do him, you can do a tattoo. You can see the improvement with the direct brow lift was good, but what was not addressed was this. Okay? Now, with what we're doing, will be something better. So we started doing the endoscopic lift on this gentleman who had a blepharoplasty and a direct lateral brow lifting by another doctor, and he came to me like this. So this is after blepharoplasty and after a direct lateral brow lift, and he came into this. And on the table, you can see his previous blepharoplasty incision right here, and his previous incision for the direct brow lift was here. So this was the first one I got, and we got some good results, and then I realized I need to support the midline more. So this is the lateral view. You see how much improvement we gave him just by the endoscopic, no more scars done on this area. And the shift now to males with no hair. So that guy had hair, the previous guy had hair, we can hide it. How about the guys who don't have any hair? This is where I start becoming more bold in approaching these patients. And this guy came to me. He is in 33-year-old, also in Dubai. He had a previous blepharoplasty done, and from his lateral view, you see his brow is sitting directly on his lashes. And he said, "Doctor, please do something." And he refused completely the direct brow lift. And for me, it's like where to hide his scar was a main concern. And I started telling him, "Look, we can do this." He said, "Do it. I put the head cover that we wear in the UAE. I don't kind, but I don't want anything on my face." So this is the first one. We did it with somebody with relatively no hair. And this is him on the table. You can see his previous blepharoplasty done. And I always take a photo and a video on the table to make sure brow positioning is good, and also to show to the patient how much we elevated. And this is him during recovery. And you can see the scars are healing very well at early stage, and you can see how much improvement we gave him to the lateral hooding that he is having. All right, so we shifted to 4 cables on men because the mid area was not able, they don't want the female look. They don't want the lateral pull that the female would want. So I added another cable to the front, and this is a gentleman who's a friend of mine from Erbil, Iraq. And this is after toxins, after fillers, to get rid of, he had a line here and a line here, but he always looked angry. And this is his best smile that he can give. This is smiling face for him. And his wife telling me, "Doctor, please," all his employees tell him why you're angry, why you're mad, and this is with him smiling. So what we did on him is the same procedure. Sorry, let me go back. Okay. So this is him before. This is with toxin. More than that, I will drop his brows all the way, and he will not be able to see much. And then This is him at 10 days post-op. He did the FaceTime with his mom. He told him, remove the filter. She said, never seen him smiling like this. And he said, no, this is not filter. This is me. And now you can see his before and after immediately. You can see how heavy he used to be. So, under very thin, heavy brows, June 30, and now you can see the post-op. Even by pushing him down, no, it's okay, I'm not putting it on, so I can do the boring if I need to.
Open eyes, the brow was coming.
So you can see the improvement, and you know the incisions are not showing, and you know his same haircut. He did not have to put his hair up or anything like this. So this is at 1 year follow-up, and you know the scars. If you can look for them, they might be here and here. So this is has become a repetitive, good indication case. And finally, I'm going to show you this case where combined it with a blepharoplasty upper and lower with a repositioning. This is a guy from Australia. He's originally Lebanese also, like our friends, you know, the Brazilian Lebanese. This is an Australian Lebanese who lives in Dubai. And his friends are telling him, you know, stop, you know, he has nightclubs, and stop, you know, staying up at night, stop drinking. And he said, Doc, I don't drink. You know, I have nightclubs, but I don't drink. But everybody's telling me, you know, you look so tired, you need to stop drinking, stop staying up at night. So this is him like that. So we did the lower blepharoplasty with fat repositioning. We did forehead lifting on him, and no upper blepharoplasty was done. So this is him with, they will complain of a bump here and bump here for the next, you know, maybe 3 to 4 weeks. And this is him, the 3 videos. I will go one by one to show him his before.
December 19, 2024. Big close your eyes. Right, open. So we have
You can see how much movement he has.
all of this and all of this.
And if you do toxin on him too, you know, see he's almost Mephisto without any toxin. So if we do any toxins on him, we might make him looking more angry and more Mephisto-like than the usual. And then at 3 weeks, he became like that, still swollen.
Endoscopic forehead lifting. And lower blepharoplasty. The eyes looking perfectly normal. The incision are already very well healed.
Yes. Yeah, well, well, not, yeah. Yeah. I'm taking advantage, Dr. Sami. I added a small part. Yeah, and this is him at 10 weeks. Okay? All right. Because also George Bitar is not here.
Anyway, Frank had a very
Okay, good. All right. So let's keep going then. So basically, this is one last one. This is a young Brazilian guy. So he came in from Brazil, very young guy, 27 years old. You know, had tried toxin and all that for him. And he did, the nice thing, he did his own video that shows his improvement. And you can see him. So he documented his recovery. And you can see how much movement. So it's not aging, it's hereditary people, both men and women who have that heavy forehead. So you can see the improvement and how much he is happy. And he's been referring a lot of males for our practice. He does live in Dubai. All righty. Thank you so much. Now,
Thank you, Firas. Let me call the next one. The next speaker is going to be Professor William Watfa from Lebanon. Welcome. He'll talk about double chin contouring, lipo, laser, or enzymes.
Plus minus عدد السنين.
morning. These are my disclosures. Today in the audience, I know we are mainly plastic surgeons. Maybe there are some dermatologists, or no, that's better maybe, because today I'm going to tell you about a growing demand we're all facing as plastic surgeons. It is what the patients call double chin. It is actually submental fat, stubborn in that area, and they want also some contouring. Now, what's the issue? The good thing about it is that it's affecting males, like my previous speakers were saying, females, all kind of ages, and it's growing in popularity. However, the patients are faced and lost with what kind of treatment can I do? So definitely we hear a lot of doctors delivering enzymes. We know there are many enzymes in the market, but now we as plastic surgeons can also differentiate ourselves. I think the gold standard is liposuction. We all mainly do that, but what I have discovered in the last 2-3 years is combining it with an energy device based. And let's see why. I personally chose to take the laser lipo assisted. Why? This is an old technology. It's the one that has been the most studied, and contrary to what it looks, it's been there in the market for more than 20 years. One of its advantages is a quicker recovery. It does coagulate at the same time, and what we also want to address is some skin tightening. Now, what does the literature say? I did my homework and looked at the literature to see the efficacy of doing that hybrid technique. And in fact, results were aligned with a better efficacy than a liposuction alone. And most importantly, it showed also the less result of doing enzymes, which would repeat many sessions, not in a precise manner. Now, today we have to answer our patient expectation and deliver a good outcome. This is what is the main headline everywhere. For this, we as doctor, as plastic surgeon, we have now, when we use a tech-driven tool in addition to our practice, we are getting definitely more conversion, but we are also being able to deliver a better result, whether it's in laxity, whether it's in lipolysis, and mainly for a quicker and smoother recovery. I do it in 5 easy steps. My drawings are standard, classical. I will first draw the submental area that needs the most of liposuction debulking, and then I can also address the contour of the jawline. For this, I will use 3 puncture incisions, one on each angle and one in the submental area. That being done, I've drawn in front of the patient. She sees also what I'm addressing. I can then start with the laser treatment. And I will take the occasion to also tell you that, I post these on social media, and I've noticed that the patients are driven by the tech-appealing appearance of this red dot. And indeed, other than doing some skin contraction, it is also getting me more patients. I will then remove the fat with a classical lipo-assisted device. And once this is done, the patient can see immediately a result. Skin tightening will definitely happen over the months, but I make them wear a 10-day garment. So in terms of results, you see that we are not only addressing the fats at the submental area, but also doing some definition. And like I said, it's not only females, also males are coming for this procedure, young patients, older patients, thicker patients. We have a wide variety of profiles coming for this procedure. And for me, the take-home message is we have to differentiate ourselves today with a competitive market. Patients are having higher expectation. They want a tech-driven clinic. And maybe if we can help them a little bit and make it your own signature, you can differentiate from other specialties who are also offering the same treatments. Thank you.
Okay, our next speaker now will be Dr. Elie Daguerre. Yes, welcome on stage, talking about deep plane direct brow lift. So we'll see another variation of the same theme.
Daguer. I'm a plastic and reconstructive surgery resident at the University of Balamand. Today, it's an honor to stand in front of you presenting a huge achievement in the aesthetic and the reconstructive surgery. I'm going to start my presentation by an introduction and a quick anatomical refresh, layer by layer. As we all know, we have the skin, the subcutaneous fat, the superficial frontalis fascia, the frontal muscle, the subfrontalis fat, the orbicularis oculi muscle, the ORL, and the preseptal fat. As we all know, broaptosis is a key sign of aging. It affects the eye area's appearance. I had the chance to participate in a prospective study which was conducted for 2 years back in 2023-2024, which included 45 patients, 35 of them were women, 10 of them were men, and the average follow-up period was about 3 to 18 months. The surgical technique adapted was a deep-plane approach. It consisted of transacting and suspending the orbicularis oculi muscle, presenting a refined way to improve the brow elevation, the brow fat suspension. It reduced the depressor action of the orbicularis oculi muscle and scarring, and it improves the symmetry. Now, how did it improve the symmetry? In our previous published technique, brow suspension in the muscle was used to achieve symmetry, but the issue was that the symmetry was subjective and the results were inefficient. In our new approach, we concluded that cutting the muscle and observing its elevation, because it's attached to the ORL. Its advantage is that the symmetry is now automatically achieved due to the orbicularis oculi muscle dissection, which is linked to the ORL. Now, what are the indications and who are the candidates for this procedure? Patients who suffer from broaptosis, those who have heavy brows with deep forehead wrinkles, patients who desire for elevation preserving the hairline, those who suffer from asymmetry with unilateral brow descent, elderly patients who have redundant forehead skin, men with receding hairlines, people who have thick skin, sebaceous and heavy brows, and patients who have facial nerve palsy and request unilateral ptosis correction. Now, various are the factors which contribute to broaptosis, including the natural process of aging, neuromuscular diseases, and the injuries affecting the facial nerve. Now, it's so important to document the brow symmetry, the shape, and the fat volume. Note that it's recommended to inject Botox 2 weeks pre-op to relax the depressors, which are the orbicularis oculi muscle and the depressor supercilium muscle. What are the benefits of injecting Botox 2 weeks pre-op during the surgery? It optimizes the surgical exposure and tissue handling during brow lift. Second, it improves the surgical accuracy and predictability, and it's easier to document and correct true brow symmetry, shape, and volume. Whereas after surgery, it makes post-operative brow positioning more stable. Second, it decreases the post-operative tension, and the chance of recurrence, as well as the asymmetry. And finally, it prevents active depressors from counteracting the surgical lift. Note that the corrugator supercilii is not considered here as a brow depressor. Its primary action is to draw the brows medially, creating a vertical frown line. For females, the lateral canthus line serves as a guide due to its general applicability, whereas for males, the line is drawn between the limbus and the canthal line. 3 points should be taken into consideration in our markings. First, point A, which is marked superiorly at 1 centimeter from the brow hairline on the previously marked vertical line. Second, point B, which is marked at the tail of the brow at its edge laterally. And point C, which is marked in the medial aspect at the end of the desired incision. As well as we have 3 areas to take into consideration. First, the red area, which includes the true medial and lateral depressor muscles. the yellow area where we create a lateral flare to elevate the brow, and the blue area where we should perform the peak depending on the patient's demand and the motif of consultation. Moving on to anesthesia, the patient should be in a supine position. A local infiltration includes lidocaine, epinephrine, and tranexamic acid to reduce post-op ecchymosis. We first start by a dissection, which is performed at the 90-degree angle relative to the hairline, ensuring a smoother tension distribution and butter scar camouflage. Then a skin excision is performed at a 45-degree angle bevel, preserving subcutaneous fat to maintain the skin from traumatization. Now, subcutaneous transection is performed in the middle of the resected skin area, reaching the orbicularis oculi muscle. Subcutaneous dissection continues upward over the frontalis muscle until reaching the upper incision line, then a submuscular dissection downward over the orbicularis oculi muscle until reaching the upper part of the brow hairline. Moreover, subcutaneous dissection is then performed in the crossfeet area, as we can see here. Now, transection of the orbicularis oculi muscle proceeds from medial to lateral, penetrating the subfrontalis fascia until reaching the retroorbicularis oculi fat. It is then dissected downward until reaching the orbital, the ORL region. Previously, as we said above, dissection in the crossfeet area, as we can see, was performed subcutaneously. We then proceed with a dissection beneath the orbicularis oculi muscle, allowing for the release of the muscle, facilitating its transection and its lateral fraying. Moving on to the layered closure technique. We first start by a 4-0 vicryl suture, which is passed through the orbicularis oculi muscle and the defrontalis fascia in order to tension the ORL. Additionally, 2-3 suspending sutures are then passed in the same manner on each side of the initial suture. Then the sutures secure the tissue in an upward position, ensuring a significant brow elevation. Now, bilateral subcutaneous cuffs are then resected from both sides, noting that this is the only step where the surgeon holds the skin directly. Now, subcutaneous closure follows with inverted interrupted 5-0 monocryl sutures. The skin is then closed with 5-0 nylon intradermally, removed 10 days post-op. Finally, the skin closure is finished with interrupted 6-0 nylon sutures in order to ensure an apposition of the scar, and these sutures are removed 3 days post-op. As we can see, this is the case of a 40-year-old male patient who underwent a deep plane direct brow lift and a lower skin resection only, showing the power of the brow suspension. Preoperatively, we can see some brow ptosis with upper eyelid hooding, whereas at 1 year post-op, we can see elevated brows, improved eyelid exposure, and restored facial harmony. As well, preoperatively, we can see some lower eyelid laxity, tear trough deformity, and mild mid-face descent. 1 year post-op, we can see smoother lower eyelids, a refined lid-cheek junction, and improved mid-face projection, confirming the procedure's effectiveness and long-term stability. We have faced one case of transient hyposthesia, which was resolved 3 to 5 months, one minor keloid, which was successfully revised, and no permanent nerve damage was observed. Because the incision was made directly above the brow, we made sure to preserve the nerve because the frontal branch of the facial nerve lies 1 centimeter above the brow, and it is protected beneath the superficial temporalis fascia, which is the safe zone for dissection. We manage very well the orbicularis oculi muscle by cutting the orbicularis oculi nerve only, preventing brow depression and maintaining long-term brow elevation, because the orbicularis, as we said above, acts as a brow depressor. In conclusion, the deep plane direct brow lift has proven to be a uniform yet adaptable approach to eyebrow lifting, integrating various advantages, features from previously established methods. As we can say, it played a huge role in enhancing the brow elevation, to stabilize the fat suspension, to have natural contouring with scar concealment, and the most important, to have high patient satisfaction rate. And thank you so much.
Thank you. The next speaker is going to be Jad Jabbar. Hello, Habibi. And he will talk about dual plane facelift.
According to Dr. Sami, we need to get back on track, so we're going to start giving less and less. Can you set it for 9 minutes, please? Timer, 9, please.
All right. Good morning, everyone. I'm Jajaba, plastic surgeon. I did my residency in Sao Paulo in Brazil. After that, I went and I did a fellowship in New York with Dr. Stephen Levine, focusing mostly on facial plastics, facelifts, and neck lifts. So today I'm going to discuss a technique that I learned from Dr. Levine and I'm applying today in my practice, and it's called a dual plane facelift. I'm going to go very quickly over the presentation, and then I have a video. We can discuss it in details. So from the name, a dual plane facelift, it's a technique that targets both planes. It's supra-SMAS in the mid-face, and it's below the platysma and the SMAS in the lower face. It's basically application for the mid-face, subplatysmal and subSMAS dissection for lower face with extended dissection, wide subcutaneous dissection, and then, of course, resection of excess skin. What are the advantages of such a technique? First of all, it's a safe and secure technique. It has long-lasting results since both SMAS and platysma are being targeted. We got malar volumization due to the plication that we have, which is something all patients usually like. We get better jawline definition, and most importantly, I think it's the quick recovery that we have. So just to compare one of the studies that was done between Dr. Baker and Dr. Hamra, comparing both deep plane and dual plane or SMASectomy. This was done in 2009. And these are two patients. One of them was Dr. Sam Hamra's patient. The other was Dr. Baker's patient. One of them, these are pre-op photos. One of them performed a deep plane lift with Dr. Hamra. The other patient performed an actual SMASectomy with Dr. Baker. And just to compare, this is a 1-year post-op result from both patients. We can see similar results when it comes to, format of the face, definition that we have, and malar volumization. This is also a profile of 1 year. No neck work was done in each of these cases. It was mostly facial work. And this is a 10-year post-op, and we can still see consistent and similar results. And this is just to show that, in my opinion, and after several facelifts that I've seen with Dr. Levine and I performed, I don't think there is one technique that's more superior to the other. And this is another 10-year profile photo. So there's no scientific validation of any one technique giving superior, long-lasting, or more natural results than the other. And just to add, 2 years ago, we did the same study in Brazil. Dr. Levine performed a dual plane lift, and Dr. Alessandro Martins performed a deep plane lift on both identical twins, and now we're still comparing results. So just to give an overview of what we do, basically, this is the vector that we have for the plication, and this is one of the most important factors in our technique. And I think this is where a lot of doctors don't understand why application is, can have good results. And I believe that having such a vector is very important, and now I'm going to show it in my video. So what are the variations of this technique? For heavy faces, usually a SMASectomy is performed. It gives better results since it reduces SMAS volumes and improves our application vectors. And 10% of my cases are usually performed SMASectomies. So where is the SMASectomy usually done? The resection is usually at the interface between the fixed and the mobile SMAS. Width of the SMAS resection usually depends on the laxity of the SMAS that we have and how much volume is there. Just to conclude, results and longevity are more surgeon-dependent than technique-dependent. There's no one best fit or best facelift technique. All techniques should have consistent, predictable results, minimal complications, consistent longevity, and most importantly, happy patients. And personally, something I learned a lot is that aesthetic judgment is one of the most important factors, and case-by-case indication is of utmost importance. Thank you. I'm going to show you a quick video. Just the video. Copy.
قادرين نسحب اليو اس بي من الفيديو السريع نشوف حطه
If a problem, we can go to the next speaker and we can show it at the coffee break.
No worries.
Okay? Next speaker, please. Dr. Saif. Saif Msia. So he's a PGY7, finishing up his residency and talking about the surgical facial rejuvenation technique. Are they all scientifically valid and anatomically justified? And Dr. Jad, we will present it as soon as it's fixed, okay?
مبين عنده دي بريزنت ريفيو بلا ما يبين ما عم نشوف Okay, good morning everyone. It's a great pleasure to be part of this amazing conference. I'm Dr. Saif Msih. I'm a Chief Resident in the Department of Plastic and Reconstructive Surgery at the American University of Beirut. I will be talking about the scientific concepts behind facelift surgery. I have nothing to disclose. So as we know, among plastic surgery procedures, facelift is one of the innovative procedures over the past years, and many techniques and advances target or address unaffected structures in the face. So this raises an important question: is facelift just about mastering a technique, or it's fundamentally a scientific concept that should be applied to restore a youthful appearance? So this sets the stage for discussing evidence-based approaches in facelift surgery. Okay, so when we address facial aging, so our basic therapeutic principle should be the precise diagnosis and treatment of the underlying etiology for facial aging, instead of doing an empirical surgery for all patients. Okay, so this takes us to the core of the subject, which is facial aging. So understanding facial aging is very fundamental to any facial rejuvenating procedures and techniques that reflect time theories regarding, as we know, the cutaneous aging, the bony resorption, the facial fat atrophy, that includes the downward migration of the fat compartments, stretching or weakening of the facial ligaments, aging of the facial muscles, and the migration of medial platysmal border. So unfortunately, the real culprits of facial aging have been subject of debate and controversy. So in our literature review, we identified 54 studies published since 2025 that objectively measures facial age-related changes. These studies include individual longitudinal studies, cadaver studies, and live subject studies that describes age changes by age groups.
So what evidence showed is that all aging theories are flawed or even wrong, and the techniques that are based on these theories are mostly empirical. So these techniques usually treat what they see, the wrinkles, the sagginess, rather than the real underlying changes. So this highlights the gap between the theoretical part and the practical part in facelift evolution. So when we talk about cutaneous aging, it's well established that skin loses elasticity with age. However, a common belief that the skin becomes thinner and it's unable to support tissues. This is not totally correct. In fact, certain areas in the face, such as the neck, we have the skin becomes thicker instead of becoming thinner. If we go to the bony resorption, so as we know, in general, the bone does not resolve with age. We have no bone loss over time, with the main exception is the maxilla, which may lose bone in certain cases, which are advanced dental disease or when we have a tooth loss. So what truly happens over time is bony remodeling. So not bony resorption, bony remodeling, which is a continuous and lifelong process. And this remodeling changes the proportions of the face, the overall shape of the face, and the angles of the face, rather than the actual bone loss. If we now, with regards to facial atrophy, there is widespread belief that facial aging is primarily due to fat loss, which lead to ptosis. However, evidence shows that this is not entirely correct. On the opposite side, we have certain fat pads that will undergo hypertrophy instead of atrophy, or some fat compartments will not change or will stay the same over time. So in other words, aging is not a uniform process, and different compartments are affected in a variable way. Okay, when we go to shifting of deep fat compartments, mainly the deep fat compartments in the face do not migrate downward with age. They remain stable in position in relative to the underlying bone. So what appears sagging is the result of the differential volume shifts in these fat compartments, and this will give us the illusion of inferior migration of the face that's often observed clinically. Now, talking about the retaining ligaments of the face, there's a misconception that these retaining ligaments in the face weakens over time. Actually, these ligaments remain stable over time and they do not become lax. And these ligaments are very important because they act as a guardian of the facial identity, and they act as a safeguard mechanism. So we should prevent over-mobilization and over-stretching of these ligaments. And by preserving these ligaments, this will give us a key to achieving the natural and harmonious facelift results. So, most of the visible changes we associate with facial aging occur in the superficial layer, and this mainly in the thin layer. The main change is in the fine retinacular ligaments, which extend between the SMAS and the subcutaneous tissue up to the dermis, and these superficial structures are the primary targets for our corrective interventions. Now, with regards to the aging of the facial muscles, actually facial muscles do not change with age, and their contractility remain stable over time. And we should avoid overstretching of these muscles, as this will lead to unnecessary and potential harm to the face, and this will give us unnatural results. And this is important when we do the deep plane techniques. We should avoid overcorrection of these muscles, as this will lead to alteration in the facial expression of the face. Now, going to the platysma, so as we know, the medial and the lateral platysmal borders actually do not migrate with age. They are strongly attached medially and laterally, and the forward migration of the anterior platysmal border is highly unlikely. Another concept is that the skin and the platysma, we have a very tight attachment between the skin and the platysma, so we should avoid wide undermining, disrupting these attachments. And since we have very tight attachment between the skin and the platysma, there's a minimum sliding between these two structures. So doing a medial application lacks any anatomical justification, and the connection between, as just I said, the connection between the platysma and the skin should be preserved, and we should not do wide undermining of the skin. So all of our surgical interventions should respect the morphology and the natural attachments in the face. So, what we should do, what's the correct technique? So theoretically, I'm speaking, what we have to do is to do a segmental preservation facelift. And what do I mean by this? Is segmental, we should treat the face in segments. So the segment that already aged, we can treat it. The segment that does not show any signs of aging, we can leave it and we preserve it. Also, another important concept from this segmental preservation facelift is to preserve the structure that has not been affected. So briefly, for the neck, we can do liposuction, closed selective myotomies, composite platysmoplasty, no submental incision, no medial platysmal application, and these procedures are not anatomically justified as evidence showed. For the mid-face and lower facelift, we can do max lift. For the jowls, which correspond to the dermal attachments of the lower lip depressors to the jowls, the superficial approach cannot be more appropriate for treating this area. Also, we can use fat and fillers injected at the origin of the muscles, which can induce myomodulation to achieve better lift.
Time, please.
Yes, less than 2 slides. Okay, also if we need an additional lift, we can do a mid-face lift through lower blepharoplasty if the patient will undergo lower blepharoplasty. For the periorbital area, we'll do direct, we will do temporal lift with orbicularis muscle suspension. This will help with the crow's feet. So conclusion, in the hands of an experienced surgeon, recent evidence regarding the immediate outcomes of ligaments release with no release are equivalent. Always avoid overcorrection. Our goal should be aimed to obtain natural, personalized rejuvenation and not a generic look. And the current priorities in facelift is safety, natural results, and short time. Longevity of the results become less critical when we achieve these 3 points. So the logical approach should be preserve the natural boundaries of the face and fixing the fixation points, and do a customized procedure and not one procedure that fits all techniques. Okay, last slide. So,
Thank you.
so this analog, just like if we have a dropping waist because of loose waistband, it's better to solve it by tightening the waistband rather than using a suspender. Thank you.
Thank you, Dr. Saif. Now just gonna see the video of Dr. Jab. It's 4 minutes video? Yes, 4 minutes, yes. And then Dr. Bitar will join us online. Yes.
So this is one of the patients that I operated on. First of all, starting off with the markings. These are very important to know whether we're going to go pretracheal, intratracheal, precapillary, or intracapillary. And this depends if the patient actually has proper crease or not. Here I'm doing infiltration. I over-infiltrate, usually 150 cc's. I use 100 saline, 50 lido 2%, and 1 cc adrenaline. Subcutaneous dissection usually is a very wide dissection. I free all ligaments subcutaneously. Zygomatic, malar, and mandibular ligaments. Here we can see our incisions being made, and I think this is one of the most important steps, is the pre-op marking and making sure we have the correct incision pattern. So, subcutaneous dissection, I always put a counter light to make sure I have a homogeneous subcutaneous flap. My aim is to have cobblestoning or honeycombing on the subcu, and this is very important. First of all, to reduce irregularities, and second of all, to preserve as much mass I can for my plication. As you can see, I go very wide with my dissections, making sure, all ligaments are freed. Retroauricularly, I do the same thing. Here we have some hemostasis, and after that, I start with the process of elevating my platysmal flap. Usually the platysma is in the deep plane. I go and I free it, and as we can see in just a couple of seconds here, we're going to see freeing of my platysma. So this is where I start the elevation. It's usually 4 centimeters inferior to the mandibula until the lobule of the ear. I get my access points, I make sure I'm in the right plane, and here it's very critical to get the right thickness of platysma mass. After that, I use my TripSat, I dissect until the midline, and I make sure all of the ligaments are free at this area. This gives me very wide traction. I'll be able to position this at the mastoid, and it's not a suspension suture. It should reach the mastoid. I also do a lateral transection 4 centimeters inferior to the mandible, and I start with my plication. This is the first suture that I usually do, and as you can see, the vectors are oblique, vertical, and not horizontal. And I believe the most important thing, whichever technique we're doing, is to approximate mobile SMAS to the fixed SMAS, be it deep plane, high SMAS, dual plane, whatever technique. This is my second suture, and these are the key stitches. The first one is the plication stitch of the SMAS, and the second is the approximation of the platysma to the mastoid. Once we do that, we can realize that we have an excess of platysmal tissue that we resect. And once we do that, we resuspend this to the sternocleidomastoid fascia. And this also gives me a better jawline, better definition, and improved jowling. One important factor is that the vectors should match. So my vector for plication of SMAS should be perpendicular to my vector of platysmal suspension. And this is how I know, if you can see, like here I drew it, it's an actual 90-degree angle. And this makes me sure that I'm in the right direction and I'm doing correct vectors. I drain all my patients. I usually keep it for 48 hours. And I think this improves recovery and speeds up the healing process. And last but not least, it's the redraping. And I think this is very important as well. Most important key points in redraping is minimal tension on the skin, especially at the lobule of the ear. In all cases that we've operated so far, no pixie ears, no problem with scarring, they're all imperceptible, and we haven't had any problems with that. I usually do deep dermal stitches, and I follow this with retroauricularly vicryl repeat continuous sutures, and at the anterior I go with nylon 5/0. 7 days post-op, we remove around 60 to 70% of stitches. 10 days post-op, we remove the remaining stitches. One important thing is also the vector of my skin does not always match the vector of my SMAS. And this is why I prefer a dual plane, is that because I can shift both vectors, whether subcutaneously or SMAS, and the way I want and the way I find suitable. So that's basically it. I'm going to show just one photo at the end. One side was done, the other side was not done, and we can see basically the difference between how much the cheek was elevated, and this is something that I like. So the right side here was done, left side was not done. We can see malar volumization. And this circle that I always put around the mouth at the lateral commissure is a no dissection zone because it creates a lot of hollowness and some joker lines. Thank you.
Okay, now will be a presentation from Dr. George Bitar, who could not make it to our meeting. His lecture will be, or his video is Finesse in Deep Plane Facelifts, Recovery, the Undetectable Scar with Elixir MD.
Hi, this is Dr. George.
I don't think he's going to be with us on Zoom, is he?
I'm a board
No, just a video. Okay.
surgeon. I'm pleased and honored to be with you here today. I want to thank Dr. Bishar Atiye and the organizing committee. I'm going to be talking about finesse and deep plane facelifts, recovery with undetectable scars with Elixir MD. Where is the facelift market today? So my practice is in the metropolitan Washington, D.C. area. We have a sophisticated international clientele, 40s to 80s, who know their facelifts like there's no tomorrow. And they expect us to deliver high-end natural facelifts with ancillary surgeries with quick healing time because they come from all over the world and they want to head back in 10 to 12 days. And we customize our facelifts to each patient. So the evolution of my facelift philosophy has evolved from a SMAS facelift and a suture suspension neck lift to a deep plane facelift over the last 23 years. I like the deep plane facelift because it improves the nasolabial folds and the midface very well. It creates more natural results. It improves the jowls, and it creates a nicer harmony than I used to see with a SMAS facelift. Sometimes I use the suture suspension neck lift in addition to a deep plane neck lift if I want to create a little bit more angling of the jawline in somebody who has very poor anatomy and an ill-defined jawline or angle of the mandible. So a deep plane facelift avoids lifting the lateral fixed mass and targets the descended mobile mass and the medial soft tissues. So it's more effective in restoring a youthful appearance, and it lifts from the medial aspect of the mass versus the lateral aspect, thus creates better elevation for the jowls, the nasolabial folds, and the labiomandibular folds, which are the things that give way earliest in a facelift. Knowledge of retaining ligaments and anatomy is crucial if you want to do a good deep plane facelift. So the zygomatic ligaments, the mesenteric ligaments, and the mandibular ligaments, as well as where the nerves pass, all should be studied in the anatomy lab and by watching or participating in surgeries with somebody who is adept at doing deep plane facelifts. So now I'm going to give you a few of my thoughts about what you need to do to get yourself the nicest deep plane facelift you can. So the first question is when to enter the neck at the midline. Well, I enter the neck at the midline when it's an older individual, visible platysmal banding, and skin laxity. If somebody's young and tight, I typically don't enter the neck. And whether we liposuction the neck or not, as time has gone by, I do less and less liposuction. So I only do liposuction about 10% of my patients who have really heavy necks. But when somebody has a mild to moderate neck, I don't do any liposuction because I feel that the layer of fat on the neck gives a nicer, more youthful appearance than the old neck lifts that we used to see that the skin was sunken in or tethered to the underlying structures. I don't do any laser-assisted liposuction because I also feel that that does not create a nice neck envelope. So the buccal fat pad, I remove the buccal fat in about 20% of patients if they have a very heavy neck, or if they ask for it, or if I feel that it's going to give them a nicer result. But I don't do buccal fat pad removals routinely. Fat grafting, to me, is a very desirable thing to do with facelifts. I view it as the cherry on top with facelifts. I trained with Dr. Adam Bogan in Beverly Hills, and I have been doing fat grafting since he was the originator for the last 23 years in my private practice. I think if it's done properly, it makes the face look nicer. There are introduction of stem cells that create a nicer appearance of the skin and just a more rejuvenated skin envelope. So I harvest my fat with a multipurpose cannula. I decant with supernatant fluid. I fill 1 to 3 cc syringes, and I inject with the Sidney Coleman cannula. This is an example of a facelift with a suture suspension neck lift and fat grafting on a 48-year-old woman, and that's her 1-year post-op. You can see the fat has completely stayed there and gave her a much nicer and much more youthful appearance. So the deep plane facelift marking is, you can see here, the markings for the incision pretragal. I also mark the entry point from the lateral canthal border to the angle of the mandible, and then straight down where the platysma attaches to the sternocleidomastoid muscle. The line here is the Pittingui line, where the frontal branch of the facial nerve goes. So you can see here that she has a lot of laxity in her neck and laxity in her cheeks. That all is going to be nicely corrected once we do her deep plane facelift. So this is the incision pretragal, and in men you can do it post-tragal or very anteriorly pretragal. I like to do it at the level of the tragus. And in some men, I'm going to recommend laser hair removal if they have some hair on the tragus. But in women, I do it post-tragal in everybody. And so you see here, the skin is being elevated, fast forward. And I elevate the skin all the way to the entry point of the deep plane facelift. You can see here the post-auricular incision. The skin is being elevated in concentric circles until you get to the entry line of the deep plane. This is the line of entry of the deep plane. And you can see here, the line is from the lateral canthus down to the angle of the mandible, and then a straight line down to get the fibers of the platysma as they enter into the sternocleidomastoid and attach there. And that gets elevated in one sheet. Here is the entry into the deep plane. So I do the pre-mesenteric or the mesenteric space first, and then the pre-zygomatic space, and then you connect them. So if you would like to see here, you see me entering into the line of the deep plane and extending it down into the neck. And then the next step would be to enter the pre-mesenteric space, and I'm showing it with a speculum here. And after I enter the mesenteric, pre-mesenteric space, I enter into the pre-zygomatic space. And this is the pre-zygomatic space and the pre-mesenteric space, and then I connect the two and create one SMAS flap. And you can see here the SMAS flap is being elevated with those two alices. That's what's going to be giving the lift that is nice, and extending it all the way down into the neck. So the deep plane facelift you can see here is you can see the power of the lift of the deep plane. And when you lift up the SMAS, it lifts up the whole lower face very nicely, even though it's still attached to the overlying skin medial to the entry line of the deep plane. Here is where I put my cable sutures, and when you pull on them to suture them, that's what gives this pull that is going to be long-lasting. So here you can see the cable sutures, about 6 of them in the face and about 3 of them or 4 of them in the neck. And you can see here the vertical pull that these sutures will give. You can see here it's a very powerful lift. So now let's talk about the scars, the facelift scars, women versus men. I like to do post-tragal scars on all women and most men, except if some men choose to have a pre-tragal scar and don't mind seeing that scar. But I think if you can see here, the post scars all look very natural. So let's go through a few examples. This is a deep plane facelift with quad blephs, endobrow, full face and neck laser on a 67-year-old woman. This is the lady that I showed earlier that we're doing a facelift on, and she had a deep plane facelift, upper blephs, endobrow lift, and fat grafting with laser on a 62-year-old. You can see how she has a very nice neckline and a very nice contour of her jawline. I use Artise or tissue sealant on almost all my faces to decrease the dead space and make the skin stick down to the muscles underlying. That decreases the chance of having any type of hematoma, decreases the chance of seromas, and gives makes the scars heal under less tension, because the tension is on the skin flap, not the scars themselves. I also use the hemostatic net, as was popularized by Dr. Auerswald in Brazil, and I leave it a couple of days, and sometimes I use it with a drain or with the tissue sealant. But the bottom line is that avoids having a hematoma, and I've been very blessed with it and very pleased with it. I use PRP sometimes after the laser to give the person a beautiful skin glow. You can see this woman's skin looks great after her deep plane facelift and a erbium laser and PRP treatment that were done simultaneously. We have our post-op healing protocol at the Bitar Institute that I've already shared a few of them with you, but I'd like to share some more. The main one is our Elixir MD treatment. And it is a remarkable way of reducing post-operative swelling. It's non-invasive, effective, and improves the recovery and decreases the amount of swelling. So basically, what is Elixir? It is the first and only FDA-cleared photobiomodulation device, utilizes various combinations of red, blue, yellow, and infrared photons to combat avoidable post-op issues. It's often customizable to not only shorten the recovery time, but also provide better aesthetic results. There are ranges of treatment modes: detox, cellular repair, Neoxcel, and Roxium. And I'm going to go briefly over those. So the way it works is infrared light infused energy into the skin cells, targeting areas for improvement. Their wavelengths range from 417 nanometers to 835 nanometers to promote tissue healing, reduce inflammation, and provide pain relief. There is a recovery plan with the detox, the cellular, and the going to the Roxium and Neotrix, which are technical terms for what this machine can do in terms of recovery. Suffice it to say that every patient will be on a protocol of a certain amount of pre-op treatment and post-op treatments based on what area they were operated on. So for the facial treatment, you get one detox treatment preoperatively, a cellular treatment at day 1, day 3, day 5, and day 7, and the maintenance treatments down the road at day 10. So how does the detox work? Basically, it's a treatment before the surgery. It utilizes blue light, 417 nanometers, to penetrate the skin, target the sebaceous glands, where it triggers a powerful antimicrobial response. The light excites naturally occurring porphyrins inside the bacteria to produce reactive oxygen species, ROS. They're highly reactive and destroy the bacterial cells. So by eliminating those harmful bacteria and balancing the skin oil production, detox helps to create a cleaner, healthier skin environment and reduces the risk of post-op skin breakdowns and infections. The post-op treatment modality, the cellular repair, is basically a yellow light, 599 nanometers, to increase the fluid dynamics and encourage the body's natural repair system to decrease edema and fight off infections. So the light boosts the lymphatic drainage by helping muscle cells and the lymph vessels contract, increasing the fluid flow and moving immune cells more effectively. This helps removing the excess fluid, proteins, and waste, and also lowers the inflammation by reducing post-inflammatory cytokines such as IL-6 and tumor necrosis factor alpha, thus decreasing the edema and promoting post-op recovery. Then you get the Neoxcel and the Roxium, which are the maintenance protocol for lighter skin and darker skin based on the wavelength that you're using. The lighter skin is the combination of yellow light, 590 nanometers, and the red light, 633 nanometers. The Roxium is for darker skin, uses a combination of blue light, 417 nanometers.
We're gonna cut it short because he's just talking about the Elixir MD. We can just, so the surgical part is done, and I think this is all published data. We can contact him directly. Huh? Yeah, no, yes. So we're gonna move to the last speaker. No, of course. Dr. Ilyas Sawaya now, of course, our last speaker for this session, and then there'll be discussion if we need to. Thank you. But we had to cut that thing because there's 7 more minutes in it. All right, Dr. Ilyas Sawaya, please. And his topic would be insights and sights from the inside. Wow. Living human tissues.
Good late, long morning, everybody. It's always an honor and a pleasure to be able to share in the homeland, so I thank you for that. My talk may come as an elephant in the room, nevertheless, I hope you enjoy. So, what is it that holds things together in the human body, as gravity does for Earth? As early as the 16th century, physicians have endeavored to dissect, describe, and illustrate the human body for us to start to understand. The conventional vision of that is that of superposed layers of specialized tissue. This has led to the depiction of human body as a sort of layer cake with occasional retaining septa and aponeurosis. But is it really as simple as that? Simple observations are often the most relevant. If the skin was simply as a garment placed on the underlying tissues, this is what we would observe. However, in real life, this is what we really observe. You have nearly vertical lines, as if there was vacuum beneath the skin. Of course, you know that is not true. So what are these inner forces? There must be more at hand. All that is available in anatomy textbooks are vague descriptions of this connecting tissue. And for a reason, even though surgeons are the most privy to observe and study these structures, our daily routine thrusts us neck deep into repairing damaged organs, no time to contemplate. Cell biologists, on the other hand, have more time and equipment. Their raison d'être is to study organic matter in depth. So human tissue has been dissected, broken down, flattened between glass slides, tested, analyzed, colored, quantified. Electron microscopy even gives us a 3D preview of tissues. Yet again, all this was done on dead tissues most of the time. Our textbook vision of connective tissue broadly looks like this. Yet life is motion and should be described as such. What if we took the time to take a close look at tissues alive? So equipped with little more than an endoscopic probe and an HD camera, we set to study human tissue in vivo. So to give a sense of the reach of what we seek to observe, this is a car and its minute details. But you have never seen this, you have to admit you are missing out on something. So the skin surface is obviously not smooth. It's an array of roughly similar mounds defined by creases diving into the depths. Electron microscopy gives us these live observations. Under tension, these mounds and folds distort and elongate. They snap back into position. Going deeper, this is an illustration of the level of detail we can attain. So you see the capillary loops and even the red blood cells flowing within. Going back to the skin, we notice that it does not stretch, rather it unfolds, with memory of form, as if the folds were tethered to the depths. And indeed, we can observe a network of fibers emerging from beneath the skin and pulling it down to the deeper planes. These fibers not only harness the skin, they penetrate the dermis and epidermis up to the surface. Dermal papillae are in fact the result of the accordion effect. Moving to deeper planes, we notice this fibrillar network is ever present, sometimes loose, sometimes more compact, always continuous. Even in planes seemingly void, hundreds of fibers deploy under traction. These fibers even suspend and sustain vessels, and they mingle with aponeurosis around. This is a vein at the forearm. They also penetrate the muscles and sustain muscle fibers. As well as the periosteum. And even the mineralized bone trabecula are disposed in the same manner. So in sum, a fibrillar network appears to span from the surface of the skin to the core of the bone, at times loose, at times encompassing a specialized tissue. What should we make of these observations? How can we attempt to interpret this chaotic organization and its dynamics? Electricité du Liban provides evidence that within apparent chaos, a functional order can nonetheless emerge. Turning back to the skin surface, and however closely we zoom in, what we seem to see are polygons of folds, dividing into polygons of folds, like Russian dolls. Folds that are ready to deploy and give way in any potential direction. Subject to tension, these folds give in, those perpendicular to the vector of tension disappear, and the folds reorganize and reassemble themselves in a linear fashion. And then they snap back into place when the tension is relieved. Moving deeper to the fibrillar network, whatever the level of magnification observed, the structure is similar. Fibers break down into fibers that break down into fibers, etc., with seemingly no end. This is the definition of fractal organization. But since living matter is not infinite, the ultimate breakdown proves to be proteoglycans saturated with glycosaminoglycans, and we'll get back to that later on. So the elementary dynamic unit can be envisioned as a polyhedron capable of absorbing forces, responding through distortion, and then snapping back into place. The fibers that constitute it are constantly ready to re-elongate, slide along one another, and even split in order to absorb the applied tension and redistribute it throughout the tissues. This seemingly chaotic array of fibrillar polyhedra, organized in a fractal manner, ensures that our tissues remain ready to accommodate any intrinsic or extrinsic vectors of tension, thereby defining the natural resilience of our tissue architecture. Functionality despite chaos, chaos and yet resilience, somehow reminds me of our country. In light of these observations, one is tempted to imagine that the biomechanical structure and function are sustained by a fibrillar architecture, spanning from skin to marrow, ultimately giving their form to complex organisms. Within this matrix, cells integrate and support both biocellular and physiological functions. Organs thus remain simultaneously mobile and cohesive, with an inherent memory of form. Beyond contemplation, what could be the clinical applications of all this? For one, observing this rich and complex architecture, I personally find it difficult to justify disrupting the natural guiding plane in the subpectoralis muscle. So in breast implant surgery, I turn to the subpectoral plane only when unavoidable, making it the exception while favoring the naturally less mobile space between the gland and the muscle. As pointed out earlier, the molecular endpoint of the fractal structure of connective tissue is an assembly of proteoglycans and glycosaminoglycans, the most notable of which is hyaluronic acid. So when hyaluronic acid is instilled within the tissues, it nourishes, lubricates, and hydrates the fibrillar architecture, ultimately producing the effects we recognize. As a rough surgeon, I never thought much of mesotherapy, but now I have anatomical proof that it is effective also. So lipofilling, stem cell therapy also has an effect on these fibers, but at a biocellular level this time. Following surgery and the destruction of the mobile fibrillar system, it appears logical to aim at rehabilitating not only the treated organ, but also the surrounding tissues, failing which immobile fibrous adhesions and septa are likely to develop. This concept is well established in orthopedic surgery, where early mobilization of the entire musculoskeletal chain has become the gold standard, not to mention post-cosmetic surgery care such as manual or mechanical massage. Finally, it is reasonable to assume that energy-based devices, in addition to the effect on the skin, primarily exert a retightening effect on the subcutaneous fibrillar fascia, which in certain clinical situations has become excessively lax. These are but a few examples of how our surgical and medical practices can be refined in light of these endoscopic observations. Thank you for your kind attention.
Thank you, everyone. Before we go to coffee break, you know, there's 5 minutes for discussion to all the speakers that were here, from Dr. Romeo, Dr. Fabio, Dr. William, Dr. Eli, Dr. Jad, Dr. Saif, and of course, Dr. Elias. So question, if you have any, please come to the microphone, mention your name, and ask the question. Otherwise, enjoy coffee break. Thank you.
ماشي الحال. هاي كيفك؟
هيدا النكست
ليك في بتنعمل
فول سكرين؟
فول سكرين
يلا
إيه
أكيد.
بضايقني هيك لانه
اوكي
بتوترني ايه بس let me check if
ازيدك بهيدا.
يا هلا اعطيني 10 ب 10 خير هم بحكي اكثر بيسترجوا يسكتوني جايبيني قبل بوقت خليني اشوف الثاني
يلا اكيد.
انا قد ما بدك بحكي هلا انت وذوقكم خليني بس فول
يا
سكرين
كمان.
كمان كيف بعملها اثنيناتهم يكونوا فول سكرين
انا بقلب لك اياهم ما تعطيني
أوكي.
الدكتور.
We will start in 1 minute. Allow me to present Dr. Micheline Mameri Shalouhi, who is a dear friend for the Society of Plastic Surgery. She is past president of the Lebanese Society of Dermatology and one of the few ladies who presented or are presenting. And she's an expert in medical dermatology as well as aesthetic dermatology and medicine. Please.
Good morning, everyone. Thank you, Tony, for your kind presentation, and I want to thank the organizing committee for inviting me to speak at your Congress. It's the first time for us dermatologists to be invited, so I'm going to definitely exceed my time and make use of the podium as long as possible until we get to the first presentation. Okay, so the first presentation is about skin boosters. And are skin boosters a better option than hyaluronic acid fillers for the treatment of the tear trough deformity? Over the past few years, you have noticed an increased demand for tear trough treatment because of two reasons. One, because of the trend to take selfies, and second, because of the zoom boom. Now, in both situations, the camera can definitely enhance or exaggerate the tear trough depth, and this can create a certain amount of insecurity and low self-confidence, especially for the younger generation. So briefly, the tear trough is this concave deformity of the orbital fat that usually measures 1 to 3 centimeters, and it is classified as class 1, 2, or 3 based on the absence or on the severity of the orbital fat bulging. And despite being an important aesthetic concern, the exact etiology of the tear trough deformity has not been well defined and is thought to be multifactorial. Now, there are several treatment options for the tear trough deformity, and this can be surgical or non-surgical. Of course, for the surgical, you are the experts, but just as a quick reminder, surgical fat pad removal, autologous fat grafting, and fat repositionings are all great treatment options, and they can yield very good results, but we do know that they have their drawbacks, and this is why many times we see the treating physician and the patient agreeing on a non-surgical approach, and so far hyaluronic acid fillers have been the benchmark or the gold standard. Of course, different factors like skin quality and tear trough severity should be considered when comparing these two techniques. So when hyaluronic acid fillers are used, they're going to improve the tear trough through two mechanisms. One, by their filler or volumizing effect because of their rheological properties, and second, by myomodulation, which means that when the hyaluronic acid filler is injected underneath the orbicularis oculi muscle, it will provide support and it will improve its tensile strength by increasing the distance between the origin and the insertion. There are several prospective studies on the efficacy and safety of hyaluronic acid injection in the tear trough deformity that have shown great results. Actually, the results can last more than a year and they yield very high patient satisfaction. And if you take a look at this table, you're going to see that most of these products we're quite familiar with, and most of them have used them throughout the years with different experiences. Now, in these studies, they injected the fillers using a needle or a cannula or a combination of both. So which technique is better in this delicate anatomical area? In this very interesting systematic review, they checked the aesthetic results and the adverse event for both techniques, so needle against cannula. And after reviewing 42 articles, they found that there is no statistically significant differences in the reported aesthetic results on the long term, and there are no statistical differences in the incidence of adverse events. So far, we cannot claim that one technique is superior to the other in the tear trough. Now, how about the most commonly reported complications? We know that there are short-term complications and long-term complications. So this is a review of the literature where they looked at the long-term complications, which means 18 months and above. and they found that the Tyndall effect, or the gray-bluish discoloration, accounted for 30% of the cases. Contour irregularities accounted for 30% of the cases, and chronic malar edema accounted for 11% of the cases. Now, how about the incidence of these complications? Again, in the systematic review and meta-analysis, they found that eventually 1% of the patients are going to develop a Tyndall effect, 5% of the patient will develop contour irregularities and lumps, and 19% will develop some form of an edema, and in this article they do not differentiate acute from chronic edema, but we do know that complications are underreported, so if we want to look at these numbers, they're quite significant, and probably they're underreported, so the incidence of complications is actually higher. So we know that you cannot avoid completely having complications, but we can reduce the risk by a proper patient selection. And while absolute contraindication for tear trough filler are the same than any site on the face, which means a history of hypersensitivity to any of the component of the filler, an autoimmune disorder, an active infection at the site of the injection, and a previous permanent filler in the vicinity of the tear trough, it is generally recommended to exert caution in patients who have a poor lymphatic drainage and a poor skin laxity. But having a grade 3, let's say, or a class 3 tear trough is not a contraindication for HA filler. So what about product selection? Product selection is also very important to avoid complications, and we know that different products have different rheological properties, so they have different level of cross-linking, different particle size, different concentration, and different elastic modulus. And though the immediate results might look the same for all fillers, on the long run they're going to behave differently in the skin, and they might yield different adverse effect or different complications. For example, a filler that is highly cross-linked with long and short chains is more prone to develop delayed onset inflammatory reaction because it is more immunogenic. And this reaction presents as a sudden, painful erythematous swelling at the site of a filler that was injected months or years prior to the presentation. The cause of this inflammatory process is what we call a reaction to a superantigen. So the immune system is recognizing a superantigen and then cross-reacting with the filler. And the incidence in the tear trough has been reported to be as high as 4%, so it's not a low percentage in the tear trough. We see this reaction in the setting of a viral infection, so an upper respiratory tract infection can trigger this reaction, and this has been reported with COVID-19 infection and even with the vaccination. On the other hand, products that have a high G prime, that have a big particle size, that are more concentrated, can attract more water, and therefore the complication that is frequently occurring with these products are this unsightly Tyndall effect, but also because high G prime products are not massageable and they're not spreadable, so they're going to resist deformation. Patients with a high G prime filler will present with these nodules and these lumps in the tear trough. So using skin boosters, can we really avoid complications while having the same clinical results than HA fillers? First of all, let's agree on what is a skin booster. By definition, a skin booster is any product that is capable of moisturizing the skin, has antioxidants effect, and can enhance collagen production. It can be a hyaluronic acid that is cross-linked and non-cross-linked, but also PRP, polynucleotide, and PDRN have been classified as skin boosters, and several studies have shown that these have favorable results in the periorbital area, so they can have some periorbital rejuvenation effect, but not enough to fix the tear trough depth. So what about non-cross-linked HA skin boosters? There are few pilot studies that were conducted, and these have shown that non-cross-linked HA skin boosters, whether injected with a cannula or a needle, have very good periorbital rejuvenating effect in the sense that they can improve the overall appearance. So we can see that there are less wrinkles, the area looks brighter, and there is even improvement of the tear trough. The only problem with these products is that they do not last more than a year because they're not cross-linked. So how about cross-linked HA skin boosters? There are no studies conducted, maybe because it contradicts a bit the FDA approval of the drug companies, so it's not in their favor to conduct these studies. So I will share with you my experience with a cross-linked HA skin booster from Nasha Technology that I have been using for more than 7 years with more than 100 patients injected. So this product is 12 milligram per ml in concentration as compared to 20 milligram per ml for a filler. It has small particle size particles, so they're small in size, and it is cross-linked with less than 2 parts per million of BDDE, and it is a biphasic product. I use a 22G 40 millimeter cannula, and the point of entry is always the lateral zygomatic area. So pictures are always taken before and immediately after, and I use 2 kinds of light, so a strong light and a dim light that shows better the shadowing effect. All of my patients were followed for at least a period of 18 months, and they all showed very good results at 18 months. None of the patients had any complications like a late onset inflammatory reaction, tyndall or nodules, and you can see even here the very good results at 2 years for class 3 tear trough deformity. So finally, if you want to weigh the pros and cons of HA fillers against skin boosters, and taking into consideration the results, the complications, and the rheology, I think we can safely conclude that a cross-linked HA skin booster is a good alternative for HA fillers and the tear trough deformity. We move now to the next presentation. And can I have the next presentation, please? Sorry. So the next presentation is everything you need to know about hyaluronidase. And sorry, I have to go back. So everything you need to know about hyaluronidase, and I have chosen this topic because hyaluronidase is an emergency kit. And like so many other emergency kits, we feel so comfortable and safe having them around, except that when you have an emergency, we all forget how to use them. So this is just to refresh your memory. And hyaluronidase is an enzyme that breaks the bonds that link the repeating disaccharide units that form the HA chains. In mammals, it is present in several organs, and it is present in all body fluids. There are 6 different types of hyaluronidase, and the one that we use is pH 20, which is present at the head of the spermatozoa, and that plays a role in the fertilization process. So basically, all products that are available on the market in a powder form or in a liquid form are from testicular-derived hyaluronidase, and they can be from ovine or bovine origin. These are some of the products that are available on the Lebanese market, and whenever these vials reach our clinic, these vials should be stored in the fridge, so at 2 to 8 degrees to maintain the quality of the product over a long period of time. If we are storing our vials at 25 degrees, the stability is only guaranteed for a period of 12 months after the manufacturing date. These vials should be reconstituted with normal saline. Bacteriostatic saline is also an option because of the anesthetic properties of benzyl alcohol, but you have to be cautious if a patient has a history of perfume or fragrance allergy, because this is an aromatic alcohol that is used in perfume. And lidocaine is not recommended as a solution to reconstitute the vial. I know we want to decrease the pain for our patient because hyaluronidase is quite acidic and can be painful, but it is not recommended to reconstitute with lidocaine because it can change the pH of the hyaluronidase and it can affect its activity. And it is recommended to reconstitute and to inject immediately. I know that if we keep the vial for a few more days in the fridge, it will still be active, but the activity is not going to be the same. So what is the half-life and the duration of action of hyaluronidase? If you put this in any search engine, so like ChatGPT, you will read that hyaluronidase has an immediate effect and a half-life of 2 minutes with the duration of action of 24 to 48 hours. Now, this is not accurate at all, but we know that these search engines just look at different articles and they give us the wrong answer most of the time. So this is a very interesting study that I would like to share with you, where they tested the duration of action of hyaluronidase. So basically, they took 6 rats and they injected the back of these rats with a monophasic HA filler. A week later, they injected hyaluronidase to dissolve the filler, and then the same filler, so the HA filler, was re-injected sequentially with differing time. So the first day, they re-injected the filler every 30 minutes, and then they injected the same filler daily for up to 14 days. And 1 hour after each re-injection, they took a skin biopsy and they sent it for histologic evaluation to see how much hyaluronic acid there was after dissolution with hyaluronidase, so how long was the action of hyaluronidase. They found that up to 3 hours after hyaluronidase, no hyaluronic acid filler was detected in the tissue, whereas 3 hours after hyaluronidase, the appearance of filler material became evident again, and 6 hours after hyaluronidase, the filler material restored almost entirely to its original volume and shape, which means that hyaluronidase loses its effect in the dermis and the subcutaneous tissue 3 to 6 hours after injection, and re-injecting HA filler and successful engraftment can be done 6 hours after hyaluronidase. So if we have a nagging patient who's coming, let's say, to remove her tear trough filler, and the next day she calls you and tells you, I'm seeing the deformity again, I need to be re-injected, you can re-inject her even 6 hours after dissolution. There's no problem in that. And a frequently asked question is what happens to the native hyaluronic acid. So yes, hyaluronidase is going to dissolve the native hyaluronic acid, but the body is capable of restoring it within 15 to 20 hours, and there are no detrimental long-term effects on the skin quality. So some figures to keep in mind: hyaluronidase injected in the dermis and in the subcutaneous tissue has a half-life of less than 30 minutes, and we know that it takes 4 to 5 half-lives for full elimination of a drug, and therefore it's true that the activity will last just 2 to 2.5 hours and not 24 to 48 hours. On the other hand, hyaluronidase that is injected directly in the blood vessel has a half-life of 2 to 3 minutes, and its activity is not more than 10 to 15 minutes, and even repeated injections did not result in a sustained elevation of serum levels of hyaluronidase. This gives us an insight if you have a vascular occlusion, so injecting the hyaluronidase in a place far away from the filler is not going to do anything. So it's only feasible under ultrasound guidance because of the just very short time of action of hyaluronidase in a blood vessels. So how many units of hyaluronidase are needed to solve adverse events or complications? The dose of hyaluronidase depends on the indication. So is it an urgent versus a non-urgent complication, the location of the filler, the volume of the filler, and the physical properties of the hyaluronic acid to be dissolved. As mentioned previously, different products have different physicochemical properties, so they have different tensile strengths, cohesivity, elasticity, concentration, and they can be monophasic or biphasic. Two interesting studies in the literature that were published on in vivo effect of hyaluronidase on different hyaluronic acid fillers. So one study compared the effect of hyaluronidase on Juvederm Voluma, Restylane Lift, and Juvederm Ultra, and they found that Juvederm Voluma required higher doses of hyaluronidase than Restylane Lift and Juvederm Ultra for dissolution, which means that highly cross-linked products are slower to dissolve. And another in vivo study that compared hyaluronidase on 6 different products, they found that Restylane was the fastest to dissolve and Belotero was the most resistant to degradation, which means that biphasic HA fillers dissolve faster than monophasic HA. This is a more recent study published in the PRS, very interesting study, because basically they took 21 fillers. So I'm sure that one of the fillers that you're using daily in your clinic is among these fillers. And then, so they've put these fillers on slides. This is an in vitro study. And they added 20 units of hyaluronidase to 0.2 ml every 30 minutes for over 3 hours. And they found again here that Restylane Lift was the first one to dissolve, so I don't know why the pointer is not working. So Restylane Lift was the first to be dissolved, and Juvederm Volux was the most difficult to dissolve, and there was a spectrum. So it's interesting for you to see where your favorite filler for a specific anatomic site lies on this graph, just in case you have a complication. So how many units of hyaluronidase are needed? For uncomplicated nodules, there are no accepted standardized guidelines, but a rule of thumb for treating these nodules is that it takes 5 units of hyaluronidase for every 0.1 ml of hyaluronic acid that is concentrated 20 milligram per ml. This does not apply for Voluma. You have to double the dose. And to take into account the anatomical area, so the same product that is injected in the infraorbital area that will take 10 to 15 units of hyaluronidase will need 15 to 30 units if it's injected in the nasal or the perioral area, for example. These are 2 examples from my clinic. So a tiny bleb like this one. So the patient is happy with her lips, but she's complaining about this tiny bleb. This will take just 2 units to dissolve without affecting the rest of the filler. And for example, this patient who was injected by another physician and had more than 1 ml in each tear trough, so 10 units were enough to dissipate almost 80% of the filler, and you can all session just to remove as much as you need without removing the entire product. So what about complicated nodules? It depends if they're inflammatory or non-inflammatory. Inflammatory nodules will take around 30 to 300 units of hyaluronidase, and this can be repeated every 48 hours until resolution. Whereas for biofilms, it is not contraindicated to inject hyaluronidase, but you have to be cautious to start antibiotics for at least 2 weeks, and then start with a dose of 500 units of hyaluronidase, and then titrate up and repeat every 48 hours until resolution, just to break the walls of the biofilm. What about vascular occlusion? Still, the recommended guideline is to use the high-dose pulsed hyaluronidase, which means 1,500 units every 4 hours until resolution of the ischemia. And the protocol is to flood the area, so to use 10 ml and to flood the whole ischemic area. And you can see here the very good result in this patient. So her occlusion resolved completely, and she was left basically with no scarring at all. There's an interesting study where they used a different concentration of reconstitution. So they use a hyperconcentrated scheme, so reconstituting the vial with 2 ml and another vial of 4 ml, and they injected the 2 vials simultaneously up to 4 to 6 cycles, and they had very good outcome in 35 cases of occlusion. So we're still just at the beginning of testing which protocols are better, but this is a very good also study and things. So I kept her in the clinic. 1 hour later, she had this severe swelling, which resolved after taking oral steroids and antihistamines. So yes, have an emergency kit for your emergency kit. And task, so just put your fillers over different slides and just add hyaluronidase and see how each product is going to react, so that you know how much, if in case you have an occlusion, how long-lasting this product is to dissolve with hyaluronidase, or how easy it is to dissolve it with hyaluronidase. Thank you very much for listening, and thanks again for the invitation.
We now introduce Dr. Hussein Abu Khalil. He is an international speaker, expert, and certified trainer plastic surgeon. He will present in a serious way, but at the same time, I think it's going to be funny, the lip story.
I will try to be serious. Thank you. Thank you, everyone. I'm Dr. Hussein Abu Khalil. I'm a plastic surgeon and international speaker, and it happened that I'm also trainer for aesthetic procedures, and today I will be talking about lips. Why lips? Because whenever you're happy, you smile, and when you smile, you're using your lips, you can't wait to tell about it. And whenever you start telling the story, you use your lips. Actually, this is not the only reason that we need to talk about lips. We have here a poll. Actually, it was done in the UK, and look at the number. 24% of those 50,000 people, young people, what do you like to change? They chose lips. And this was done on social media. Through social media, actually social media is where we live today. And believe me, this is how you look like every night when you go to bed. Everyone in this room, you look like this when you go to bed every night. And this is not out of our power. We are guilty for this, because this is what we post on social media. And that's why frequent users of social media are thinking about new lips, because this is what they see on our pages. Actually, it's not only us, because influencers are coming to our clinic. They are posting, yes, it's from the video. They are posting this on social media. We are reposting, actually, and this is our story with lips. But let's think about the real story, the true story behind the story. Here we have some lips. We did a very simple technique because we had already good lips to be injected. And this is what we get. Very beautiful. We posted the result. But look at the true story behind the two figures. So we need to recognize that what we post on social media is the happy story, the happy part of the story. What about science? We use science for this, and we all know about the golden ratio, which is 1 to 1.618. Let's play a game. Tell me, which one is the most beautiful one? Choose a number. Anyone? A number. 4? 4? Everyone? 4? 4 is 1 to 1.7. Actually, 4 is a credible one, is a beautiful one, but it's not even close to the golden ratio. So actually, we're doing almost 1 to 1. What's the secret of perfect lips? Fullness, projection, and proportion. I will go faster with the cases. I will show you actually some techniques, and I will let you know that whenever we talk about proportion, we can go through the lips to change something in the whole face. And here, this is what we had. Look at the distance, look at the sad face, and working only on the lips with two different techniques in two different sessions, and we got this. Actually, even the distance between the nose and the lips, the columnar distance is smaller, and even the sad face was corrected. It's not the perfect lip, it's not the perfect result that we want to see, but actually this is to show the impact of lips on the whole face. Another cases with the satisfaction, but here the proportion is not about lips, the proportion is about lips and the face. If you look at the lips, they are not perfect, but if you look at the whole face, yes, those lips are fitting perfectly in this round face. Another case where the upper lip and the lower lip are not actually proportional at all, with asymmetry, and the technique is a simple one, and this is why we work on one of the two lips, the upper lip, to get this kind of proportion. Asymmetry actually is possible to be corrected only if we talk about static asymmetry, but it's too hard to deal with dynamic asymmetry. Actually, this is another long story. I think that you got something from my time, but I'm not going to talk about it because it's not true. Anyway, this is another story with multiple sessions of treatment, and the patient actually is asking for something which is not part of my philosophy about beauty, but this is the trend. And sometimes we go a bit with the trend. Sometimes we start with the hydration, and we find that hydration is not enough. Actually, we need another technique to add a character, identity to those lips, even if the patient is not accepting the restart, and restart means actually to dissolve the old filler and to redo the lips from start. And my last case, actually, this is why I called it a lip story, because this patient came to my clinic asking for lips only because she's not able to post a beautiful story because she's ashamed with her lips. This is how much they care about lips. We started with the first session, and she was aware that in one session it's impossible, so we needed multiple sessions. We got a bit of fullness. 3 months later, we went for another technique, and we gave her more fullness. Then we have the result after 3 sessions, of course, with the filter. I'm suffering from filter because you saw they are adding filter, and we are the doctors, and we get some filters with them. So filters are there everywhere. But talking about the take-home message, away from the product selection and the multiple sessions and everything, let's talk about the trend. The trend is a strong wave. And I believe that you may use it actually to inflate your career, but at least be selective and try to add your touch. And only then you will feel strong. And believe me, it feels much better to tell your own story than to tell the story invented by someone else. This is what I think about lips. Thank you so much.
Good morning, all. I'm going to present a paper today, our study that we did in our university about lip augmentation with soft tissue filler, adaptation, and beauty trends. So as Dr. Abu Khalil was saying, there is a rising demand for lip augmentation that is driven usually by social media and by celebrity culture. However, our patients that we see in our clinic often request exaggerated volume. However, we wanted to prove that the